Attendees are in listen-only mode.
Welcome to the Brain Injury Association of New York State's webinar, Brain Injury in Youth, Promoting Effective Concussion Management and Recovery. I am Carla Giovignello, Brain Injury Training and Services Project Director here at BIA NYS. Thank you for joining us. Before we begin, a few housekeeping details. Because of limited time, we ask that you please hold your questions until the end of the presentation. During the Q&A session, questions can be submitted via the question text box. The text box option should be visible to you on the GoToWebinar toolbar on your desktop. If you are having trouble viewing this option, please contact Citrix Tech Support at 1-800-263-6317. Again, that number is 1-800-263-6317. 6317. This number should also be visible on your toolbar. Our presenter will do his best to answer questions in the order that they are received. Any questions he is unable to address may be submitted via email to the association. We will be recording this webinar session and plan to post it along with the PowerPoint slides to our website, www.bianys.org. Information about contacting the association and viewing the recording will also be provided in a follow-up email after the webinar has concluded. Before I turn the microphone over to Dr. Dunkle, let us begin with a quick poll to see who is in our audience today. Please take a moment to answer the question. I'm going to close the poll in a few more seconds. It seems as though everyone has answered, so I'm going to close the poll now and share the results. It looks like we have a great group of individuals here, very diverse. So I want to thank you all again for participating in the webinar. We appreciate your attendance. It is now with sincere pleasure that I introduce our webinar presenter for today, Dr. Jay Dunkle. Dr. Dunkle is a trained clinical neuropsychologist and has worked at Neuropsychological Services of Westchester since 1995. He is a member of the New York State Public High School Athletic Association's Sports Concussion Management Team and provides consultation to school districts on how to best manage concussed athletes in returning to learn and in returning to the field. Dr. Dunkle, good afternoon.
Hi, thank you. Thanks for putting this together, and I appreciate being invited to do this, Carla. And in this webinar, what I hope to cover is just the nature of concussion, return to the classroom, return to play or sport, and establish a concussion program, what that entails, and then treatment, which we do at Neuropsychological Services of Westchester. What I hope to cover also is to integrate into the presentation case examples, and so hopefully we can make this worthwhile, and I appreciate everyone joining me for this presentation. So let's get started with just an overview of what a concussion is. Let me advance this slide. So concussion is a mild traumatic brain injury, as we know, that interferes with normal function of the brain. It's not a bruise on the brain. In the 1940s, animal experiments, it was realized that the head has to be able to move to sustain a concussion. The evolving knowledge is that dings and bell ringers are actually brain injuries, and we know from even in the literature that dings have been referred to in the last number of years, but they really are brain injuries. And as many of you probably know, that you don't have to have a loss of consciousness to get a concussion. Actually, I had a parent call me the other day about their their child who sustained a concussion, and she was actually told by a professional that since the child didn't lose consciousness, that they didn't sustain a concussion. So there is still information out there that is incorrect. Also, linear acceleration is an injury from front to back. So that's usually seen in an athlete hitting like the boards, like in hockey, where it's more of a front to back type injury. And typically in those types of injuries, you won't have a loss of consciousness. More loss of consciousness comes from a rotational type injury, which is more of like a spinning top, where basically the head is moved from side to side. And in most concussions, you have both mechanisms going on and occurring at the time of injury. The extent of the problem, professional athletes get a great deal of attention in the world of concussion. Like watching football on Sundays, it's now brought up many times during the course of a game, where in years past it was never discussed. So it's much, concussions are much more common in high school than any other level, just due to the number of participants in sports. So we know from some statistics from actually 2008, 2009, which is higher now, but football, there's approximately 1.5 student athletes. Boys soccer is 384,000, as you can see from the slide. Girls soccer, 345. Boys basketball and girls basketball. I'll say that also one number that's not there that I see that we hear a lot of is women's lacrosse. I see a lot of people that have injuries like that at the school level, and also soccer is listed. But this year in particular, there have been more soccer injuries just in the Northeast. And I was talking to actually an athletic trainer the other day, and we were wondering if it has to do with the amount of rain we've had in the East, because the weight of the ball becomes obviously heavier when it rains, and so the extent of concussion increases. So the extent of the problem, concussions are more likely to occur during competition than during practice. 1.8 million total athletes participate in American football, including 1.5 million high school athletes. And concussions account for about 9% of all organized athletic injuries in the U.S. high schools. So that's about 135,000 concussions a year. 4 to 5% of high school athletes will sustain concussion during any season. And there were about 19 or 20% football injuries in 2009 were concussion-related. So we see that it's a pretty significant problem, and it's becoming more and more in discussions. And there's a lot of, obviously, with the new law in New York State, it's really moved to the forefront of injuries in schools. So it's likely that there's 100,000 concussions in high school athletes yearly, and that's based on a CDC estimate. It's not just a football problem, as I said. Concussions represent about 6% of all organized, and that's football, girls soccer, boys soccer, basketball, wrestling, and softball. So now we have a question.
All right, I'm going to launch that poll question now. Please take a moment to answer the question. I'm going to give you a couple more seconds to answer. All right, I'm going to close the poll now and share the results. So Dr. Dunkle, it looks like 23% believe yes, mouth guards help prevent concussions, 57% say no, and 21% say research is inconclusive.
Okay. All right. Well, I don't know if anybody else has recently read the book by Dr. Meehan, who's out of Boston. He has some comments about mouth guards and the research on that, which it's hard, as in working in this field, a lot of schools ask me this question, and this is what Dr. Meehan found in his research about mouth guards. So mouth guards have a lot of studies about mouth guards were performed on cadavers, which I found was interesting. They found no difference in brain function between the two groups, meaning mouth guards did not prevent a loss of brain function after a concussive brain injury. In a study of rugby players wearing mouth guards and those not wearing mouth guards, it showed no statistical differences in the rates of concussion between rugby players. And mouth guards reduced the risk of facial bone fractures and dental injuries, but there was limited evidence for the support of mouth guards. So I thought that was interesting information and a question that I've been asked along over the years. And also he also mentioned about the headbands, because that's becoming more and more popular, and what he commented on was it can reduce the risk of scalp lacerations and cuts and abrasions, but didn't show the risk of sustaining concussion. And I'll get into that in a little bit, why they think that is. And what's interesting is research suggests that those athletes who sustained their concussions on artificial turf were more likely to lose consciousness than those athletes sustaining concussions on natural grass. So I thought those were just some interesting information dealing with just protective measures. So the increased risk, if not properly identified and managed, we know that symptoms can take significantly longer to recover after an injury if it's not properly managed. Players more likely to be re-injured because of one's concussability, and athletes who sustain a concussion in the past are twice as likely to sustain another concussion than those athletes who had never had a concussion. And in the study out of North Carolina showed that college football players with previous concussions were 3 times more likely to sustain a concussion than teammates who had no previous concussions. Second and third injuries are more likely to be more severe, could cause permanent brain damage, and take longer to recover. So an athlete who sustains multiple concussions will have more significant symptoms and more impressive decrease in their overall brain function, and often take longer to recover than athletes who sustain only one concussion. And in working with individuals, you do see, many of the people that are concussed, when they come back and they sustained another concussion, their symptoms are much worse. There was an individual I saw a number of years ago who had sustained 4 or 5. When he saw me, he had sustained his 5th concussion playing ice hockey, and the pediatrician had his pediatrician had decided to retire him because every time he was going on the ice, he was a player who was not dirty, but he was aggressive. So it was hard for him to manage and play in a different style than he had learned. And so the last concussion he got, his headaches were horrendous, and he really had a tough time tolerating them. And it took him a lot longer to recover from his first concussion, and then on his 5th one, it took him a long time. So it was really his decision to step out of ice hockey, in which he was the captain in high school, and also forfeit his being captain in lacrosse. So it was a hard decision for him, but one that he made and one that he had to adjust to. And now he went off to college and was playing on their golf team. So he really made an adjustment and was much happier and feeling significantly better a year later. Obviously, increased risk of retirement from sport, which I just mentioned as an example. So just a few facts about concussion. Some injuries are worse than others. Some athletes are more vulnerable, and I think that goes to just their concussability. And some athletes who sustain a concussion over the course of time, it just seems like some individuals heal faster and are not as susceptible to concussion, and others, when they get hit and then they get hit again, and it doesn't have to be a second one, but their symptoms flare. They're just more vulnerable to the symptoms. Pre-injury risk factors, previous concussions, these are things you need to look at. Headache, history of ADHD or LD, and mood. And the research suggests that when a person has a history of ADHD and LD, that their recovery rate is actually slower. Other possible factors that influence recovery, obviously the magnitude of force that was received, location that the force is received, the defensive position or prep of individual receiving the force, side and speed factors. Bob Cantu, who's a neurologist out of Boston, I heard him speak just in a like on a YouTube, and he was talking about one of the Boston Bruins players who basically he was saying that when an individual sustains a concussion and may take 3 or 4 months to recover, and then goes back and he's fine to go back, that this individual sustained another concussion a few weeks later, but his recovery was much faster. So he was saying in this presentation that you have to treat, you have to know the history of concussion, but you also have to treat each concussion individually, because sometimes if an individual sustains a second concussion, the recovery rate might actually be faster than the first. So it's tricky to kind of take all this information and kind of sift through what's the best for the student athlete. Annually, millions of children sustain TBI. 80 to 90 of those concussions are mild. New CDC estimates of sports recreation TBI alone, adults and children. So they suggest there's 1.6 to 3.8 million per year. This individual, Kevin, out of North Carolina, found that only 15% of players with one prior concussion had symptoms that lasted longer than a week. But players who had 3 or more prior concussions, 30% had symptoms lasting longer than a week. So you can see really the concussability and the history of concussion is really important, and it can last longer than a week. But as Dr. Cantu in his presentation suggested, that sometimes that's not always the case. So it can be really tricky to decipher. He Collins, who's out of the University of Pittsburgh, who does a lot of research with sports concussions. So athletes who sustain a concussion were more likely to be knocked unconscious, to suffer concussion, than to suffer amnesia if they had sustained prior concussions. So 90% of athletes who sustained repeat concussions during the same season suffered their concussive hit injuries within 10 days of one another. Furthermore, at the time these studies were conducted, many athletes were returned to sport before they were fully recovered from their concussions. And I think that's kind of one of the take-home points, is that need to be fully recovered from concussion, and really waiting enough time to make sure the athlete is fully healed. So this leaves open the possibility that if an athlete fully recover in between their concussions, they might develop these cumulative effects. So concussion is a traumatic brain injury, and it's defined as a complex pathophysiological process affecting the brain, induced by traumatic biochemical forces, secondary direct or indirect forces to the head, disturbance of brain function related to the neurometabolic dysfunction, and it's rather than a structural injury. So it's a it's typically associated with normal structural neuroimaging. So a lot of times, CAT scans and MRIs are for most part normal, but you still have people coming in saying that their CAT scans and MRIs are normal, but why are they feeling the way they feel? And they don't quite understand that these two scans are or these two imaging techniques are often normal. And concussions may or may not involve a loss of consciousness, as I said before. Concussions result in a lot of different symptoms: physical, cognitive, emotional, and oftentimes sleep-related. What we see is that in many instances, sleep, the person with the head injury doesn't have a problem getting to sleep in many times, but it's more or less maintaining sleep throughout the night. Most people report having difficulties waking up between 2 and 3, and then having trouble getting back to sleep, and usually are awake for an extended period of time. Duration of symptoms are variable and may last for as short as several minutes or last as long as several days, months, weeks, or even longer in some cases. Well, why all the concern? Well, concussion results in measurable brain dysfunction. The brain dysfunction often persists even after athletes report being symptom-free. Increased risk of sustaining more concussions. Obviously, the effects of multiple concussions are cumulative. There may be long-term effects revealed later in life. Female athletes have 49% less muscle strength and 30% less muscle girth than male athletes. And so they see that, particularly in soccer, the importance of not only teaching proper heading, but for females, that neck strength comes into play. And typically, when a female athlete sustains a concussion, that the symptoms last longer, and so the neck strength is really important. They also in studies have found that when in soccer in particular, when the athlete is prepared for heading the ball, the likelihood of concussing is much lower than the athlete who's not expecting to be hit by another player at the same time, or not anticipating that blow, because they're able to prepare their body for that, for hitting the ball. I'm not a proponent of heading the ball a whole lot, but more developing smarter techniques and smarter ways of playing the sport. It's been suggested that the female sex hormone estrogen may make females more susceptible to concussive brain injury. However, the exact role of estrogen is controversial and not totally known at this time. So here's the next question.
All right, I'm going to launch that poll question now. Please take a moment to answer the question. I'll give you a few more seconds to do so. I'm going to close the poll now and share the results. All right, so the question was, how often is a headache the #1 symptom of concussion? 13% believed it was 54.8%. 48% believed it was 94.2%. And 39% believed it was 75.6%.
All right, so you guys are good. So the correct answer is 94.2%, and that's the most often reported. Dizziness is about 75.6%, and then concentration difficulties is at 54.8% report that. So symptoms category. So we have physical symptoms, which obviously headache is the #1 symptom. Fatigue, dizziness, sensitivity to light and or noise, nausea, and balance problems. And I think for us who treat people with concussion, these really are the main physical symptoms that most people walk into the office with. Then the cognitive difficulties, difficulty with memory, difficulty with concentration, feeling much more slowed down, and feeling foggy. And people talk about that when they have a concussion, it's different than when they feel fatigued or when they're just tired. Oftentimes when we're tired, we're able to push through. But for the concussed athlete or individual, pushing through, they can't really, they can't push through. It's almost like a screensaver comes down, like on the computer, and they just can't push through the difficulties and try and do what they need to do. They can't do it. Other symptoms, emotional ones with irritability, sadness, feeling more emotional, or nervousness. And oftentimes these are not reported by the athlete. They're often reported by parents or friends. A lot of times the athlete or the concussed individual is not aware of the emotional changes within themselves. And then sleep dysfunction, sleeping less than usual or sleeping more than usual, and trouble falling asleep. So everyday functional effects: home, difficulty completing tasks at home, reduced play or activity, and irritability with the challenges that they're up against. In school, they have difficulties with concentration, remembering directions. They find themselves becoming more disorganized. They have trouble, obviously, completing assignments. They're often fatigued, and they fall behind, fail tests, or reduce grades. And I would say this on the last piece with the falling behind. Many students who are in school but they're falling behind, and then they see a reduction in their grades. That really perpetuates or exacerbates the symptoms of anxiety, because they get so worried as they're not in class or not doing all their work that they really get very, very anxious. So trying to deal with and help the school manage that and the client is something that needs to be worked out. Neuropsychological effects of concussion: obviously attention, concentration, working memory, which is the ability to hold information in mind, new learning, and memory storage or retrieval, the speed of processing, and one's reaction time. The possible behavioral or social effects: you get the verbal or the agitation, and the inability to cope with overstimulating environments, the impaired ability to perceive, evaluate, or use social cues, and that creates then more mood swings or emotional lability and impulsivity, and then you see like just a lot of low frustration tolerance, and so those things, as time goes on and the concussion continues and the symptoms continue to exist, that the frustration tolerance becomes very, very low. And there are individuals out there that lack awareness of one's deficits, and so they're not aware, and it takes others to talk to them, and maybe do some neuropsychological testing, that they start to become aware of where their difficulties are. While the duration of recovery, while symptoms, balance, and neurocognitive function are the three main components in helping determine when an athlete has recovered from a sports-related concussion. There are many other factors that are considered before returning an athlete to sport. In a study from 2003, 90% of college football players who sustained a sport-related concussion had resolution of their symptoms within 10 days. So really, it's all over the map as far as how long it takes people to recover from these concussions. Nearly 85% of high school athletes who sustained a concussion had complete resolution of their symptoms, being recovered by their athletic trainer within 7 days after the injury. And then within 1 month after their injury, 98.5% of high school athletes who sustained a related concussion were deemed recovered. But a small handful have taken a year or longer to complete recovery. So you do see those few that that take a long, long time to recover, and there's really no rhyme or reason why that is true for one and not the other. So this just kind of gives you an idea. This is from research from Mickey Collins of how long it does take to recover from concussion, and you see that with the one or more previous concussions, that goes on for a longer period of time than the ones with no concussion. Now I'm just going to kind of move into guidelines for return to school after concussion. So a lot of students are when the symptoms are continuing and they're not able to tolerate school at the beginning. So a lot of times they're out of school at first just to get that cognitive rest, and then they gradually re-enter school as they can tolerate it. And that might be, I've had in our office, we've had a number of people be in school for one class a day and then returning home and maybe doing some at-home tutoring in the afternoon, and then they slowly build up from there where they're in school for 2 or 3 classes. But for some individuals, that's hard for them to tolerate because of just the social implications, and they don't want to be, in high school, you can imagine, they don't want to be different. So that's for some that's a very hard gradual return that plays upon them just in their emotional state and needs to be dealt with in treatment. Also, to avoid re-injury, especially in physical education class and in crowded hallways, so there are accommodations to help them obviously not be in PE, and also sometimes to avoid a crowded hallway, maybe you leaving one class 2 or 3 minutes earlier, so they're the only ones in the hallway or with a buddy to get them to the next class. And also to provide academic accommodations, whether that's a 504 classification or an IEP, and then really to communicate and educate, establish one person in the school that's a liaison with the parents and the team. And many times in most schools, that's a lot of times school nurses take on that role and are really good to work with. Rest breaks during school in a quiet location, that's not always the nurse's office. One individual I'm seeing now, she tells me that when I say, did you go to the nurse's office? Well, that's where all the seniors hang out. So that's not the best place for her to rest. So we have to find another place for her to go, and maybe that's could be in the library or something of that nature. We're finding another place other than the nurse's office. Also, sometimes nurses are not in their office, so the student will go to the nurse's office and then they're not there, and so a lot of coordination has to take place within the school. Also, reduce course and workload. Not taking certain classes is important, especially some of the classes that may flare symptoms. Obviously, classes like band wouldn't be recommended when they first go back. And just decreasing homework. So if an individual is assigned 30 math problems, if they're fine, they might be assigned 10 math problems, and they do every third math problem or something like that. so they get through the exercise, but they're not having to do it for the time period they would have to prior to the injury, and they're also learning the material. Also avoiding overstimulation, obviously in the hallways or cafeteria, any place that's really noisy, that a lot of times just exacerbates the symptoms. So being able to find another place to go eat, or obviously, as I said before, leaving one class earlier to get to the next class. Also, extra time on tests, or as well as having a quiet location for tests. Provide students with class notes, or allow students to audio tape class, or have a study buddy. And I think with technology, a lot of times there's class notes now up on school websites, and the student's able to follow along if they have a computer, and then they have a study buddy to kind of write down additional notes, so they don't have to process the information that the teacher is giving and have to write it down. They can really just pay attention to what the teacher's saying and not have to worry about recording all the notes, because the less demand you put on thinking or cognition, then the better able they are to make it through the day and not exacerbate or flare their symptoms. Also allowing the student to wear sunglasses or baseball hats to help with light sensitivity can be helpful. Also, there's websites where you can get, if it's noise sensitivity, to get earplugs, and there's certain earplugs that you can get that come in threes, where it's different levels of reduction of noise. So there are those accommodations out there that can help with noise sensitivity. Sample strategies to consider scheduling modifications. So attend school part-time, as I mentioned before. Schedule the several in-school breaks. It's best if you can have like a class and then a break, class and then a break. Provide study halls with resource teacher to help them organize work. Schedule most difficult subjects early in the day if that's at all possible. Many of the school systems that I'm sure you're familiar have like rotation, 6-day rotation schedule or 5-day, and that's challenging to manage. How you're going to set up the schedule or assist the school in setting up the schedule for the student. Keep number of classroom changes to a minimum, or assign a buddy to assist the student in changing classes. Begin with one-to-one or small group instruction, and then adding additional students with improvement of concentration. And then obviously services for tutoring for the summer months, or even some students we've had, they've been in school part-time and then having at-home instruction maybe for the afternoon, so their day is really broken up so they can be in school. But the biggest thing to remember is not pushing somebody so hard so they hit that glass ceiling and then they feel terrible, and then it takes them several days to recover, and they kind of get on this roller coaster ride where they flare their symptoms, and then they have to rest for 2 or 3 days, and then they feel better again, and then they push too much. It's really hard to help the student athlete manage that and not be on that roller coaster where they're just flaring the symptoms and then feeling terrible. Also, classroom rules and expectations to be well structured and taught. Instruction should contain repetition and feedback. Obviously, avoiding multi-step instructions because of the processing issues of the person with a concussion. Supplement verbal instructions with writing, and provide ample time to process, complete tasks, and respond. Also, assist the student in keeping his or her materials and schedule organized. Teaching compensatory strategies for test taking or note taking. Try external aids such as lists or diaries or computers, and use of a calculator or also a formula sheet. And then videotaping the student's progress in class to provide feedback, because the student a lot of times they're so aware that they're struggling that they oftentimes don't don't see their progress. And a lot of times in treatment, getting parents' feedback about their progress, or talking to teachers or nursing that they seem to be doing better or looking better. Anything to encourage them along this process. For many of them, it's a long process, and it gets very tedious. If needed, an IEP, to develop an IEP, and to include the need for eligibility, the documentation, and schools seem to be pretty willing to address the students' needs and especially since this new law with the school is responsible to provide these. But it takes working out what strategies are needed and what accommodations are needed, because it's a moving target. And so as the individual improves, then the accommodations need to be lessened, but it's kind of a slow process. And so it has to be done carefully, and it has to really be involvement of the student as well as the school. And so it's just important to have these things, including having these things in the IEP that can help identify the problems, but also keep the student moving along as they continue to improve. In developing the IEP, focus on 2 or 3 priorities. Identify metacognitive or organizational strategies. Write the goals so they can be obtained. And an individual I worked with a number of years ago, she had a lot of accommodations in an IEP, and she didn't want those accommodations initially, but then as she got those accommodations and she realized she could be in school all day without flaring her symptoms or being home like she had been the previous semester, she really started to use them and incorporate them. And then as she improved, she was able to decrease the use of them, and so it was kind of a positive reinforcement that she didn't need the accommodations. She was doing better and better and getting better. And to this day, she still uses some accommodations, but very, very few. And she's done very well in school and adjusted to the injury. So also including specific information about how the strategy should be taught and implemented across settings, and write short-term goals that are truly short-term. And I think, in talking with teachers that provide these accommodations, they're more than willing to help out if they know how to help out. But a lot of teachers don't know how to help, and so that becomes tricky for them in how to grade and how to give the individual accommodations. So maybe even having a conversation with them, or just helping them think through ways in which to help their students. What must youth and high school sports programs do? Begin the process of implementing an effective sports concussion program. Outfit all high school athletic programs with trainers. There are a lot of towns and districts that don't have athletic trainers in schools. And input to youth sports programs, obviously that's coming on the forefront. Education and awareness, preseason baseline testing, organized sideline assessments, post-injury neuropsychological and balance testing, symptom assessment, and then also supportive management and recovery program to help the student athletes, and cautious and gradual return to play based on individual assessment and data of recovery. And I'll get to what I mean by data in a few moments. So when return to play, in criteria for return to play. So now we talked about the basis of concussion. We've talked about managing concussion in the classroom, and now for return to play. So obviously the student no longer has any symptoms. There's no need for medicine to control symptoms. One thing that we run into is that a student athlete will be reporting no symptoms at school, but you come to find out they're not on prescribed medication, but they're taking Tylenol and Advil or whatever over-the-counter medication that's really masking and controlling the symptoms. So it's really important to ask if there's any medication being taken at all, whether that's over-the-counter or prescribed. Obviously, cognitive and thinking skills and balance are back to normal, as well as after rest and then gradual activity or physical or mental exertion, and then need to be cleared by a medical professional. And the ZERF guidelines, recognition that the child or adolescent student athlete may take longer, and that we need to proceed more cautiously with that group. So this is just what things are considered in returning an athlete to play. Obviously, the medical factors include the symptoms, the physical findings, the physical, the headaches, which kind of plays into the symptoms observed and reported, the neuropsychological data, whether that's from impact, which is one concussion cognitive test that's used to manage concussions. Concussion factors, obviously the severity of the injury, the time from concussion, where the student's at now, the history of concussions, so the number of them, the space and the severity, and also just the player's factors, the style of play, the family issues. I just talked to an athletic trainer last night that one of the students that she has, soccer player, is the parents, the soccer player sustained a concussion 2 weeks ago, but his parents are not having him return to soccer, but more preparing for, I guess his sport is wrestling, so they're looking to see returning him to wrestling and not really worrying about soccer. So that seems to be more of a family dynamic and a decision made by the parents and the athlete. Even if he was better to return now, he wouldn't be going back to soccer at this point. Also, the team factors, the level of play. Is it a recreational team? Is it an elite travel team? Position of the player on the team, the opposing team characteristics, all those things play a part. That's more at the college level. And also the field condition or the type of surface, whether it's grass or turf, that we know the athlete is more likely to sustain concussion on turf versus natural grass. So relying on an athlete's symptom report, athletes, as we know, do underreport symptoms. This just shows a slide put out by Impact, and it shows the Impact is, as I said, a cognitive test, and as for those that know it, it has several composite scores, and these are two of them: verbal memory composite and a visual memory composite. And it shows athletes that are symptomatic, what their scores are like, asymptomatic, and then a control group. It really shows that an athlete can be asymptomatic, but still not their cognitive skills are not to where they were at baseline. And this just shows, the same thing. They're asymptomatic, but their reaction time, the reason why the reaction time, as an athlete gets cleared or feels better, the reaction time actually is faster for these two slides, and that's what you want. But they're asymptomatic, but their speed or the reaction time is still slightly slower. Also, just balance testing. This is just from Dr. Meehan's book. This is just a way to assess, and this is often done by the certified athletic trainer. This just kind of gives you an idea. And many people that sustain a concussion will not be able to maintain their balance. So this is going to give you an idea of what a balance test consists of. At this level, first, stand with their heads on their hips, feet together, and their eyes closed. And for some, you'll see them. For some athletes, you'll see them wobbling or lose their balance. Second, on their non-dominant foot, athletes must have their hands on their hips, hold the stance for 20 seconds, and then the non-dominant foot is placed behind the dominant foot for 20 seconds. And you'll see what kind of errors these athletes make. Their hands are taken off their hips, or they often open their eyes, or they take a step or stumble. They move their hip too far to one side, or they lift their toes or heels off the ground, and they remain out of the stance more than 5 seconds. So this just kind of gives you an idea of what the athletic trainers or other professionals are doing as far as balance testing. It's just a overview of that. So just an effective concussion program, education awareness, baseline neuropsychological and balance testing, on-field surveillance, standardized sideline assessment, obviously post-injury neuropsychological balance retesting after an injury, and also just the management of physical exertion and cognitive exertion, because we know that those two things in particular flare the concussive symptoms. And then obviously determining or coming up with a gradual return to play protocol. So we have the next question.
All right, I'm going to launch the poll question now. Take a moment to answer the question. Give you a couple more seconds to answer that question. All right, I'm going to close the poll now and share the results. So the question is, will this concussion program remove athletes from play longer? 37% answered yes, 56% answered maybe, and 7% answered no.
Okay, so you were correct again. I think I put all the correct answers as B, which I didn't mean to do that, but anyway. So yeah, having an effective concussion program may or may not hold an athlete out longer. I mean, hopefully the goal is when the individual is ready to return, it will return them in a safe way, as well as the athlete who thinks they're ready to return and not ready to return. It does hold them out for a little bit longer, because you have a lot of people in a concussion program evaluating and watching and determining when the athlete is safe to return. So anyway, so let me go back to obviously the education awareness, the baseline neuropsychological and balance testing is important, and that can be done with impact and obviously in balance testing, and duplicate slide, which I'm not sure how that occurred. But we'll move on to the next one. So to evaluate concussion recovery, we cannot rely on athletes' symptoms report, as we know, alone. And how many other injuries do we allow the athlete to decide when they can return to play? Not many. So preseason baseline, impact is a 25-minute computer-based test, which many schools now use. It assesses memory, processing speed, reaction time. It also has a 22 question symptoms, which are consistent with concussion, and the individual goes through those questions, and if let's say they endorse, nervousness at baseline, then if they endorse that, then there's another scale that they go to and it asks the student to rate them on a scale of 1 to 6, 1 being very, very mild, 6 being severe symptoms of nervousness. They can be conducted in a group format. It's loaded on computer labs, and then the baseline data is available for comparison post-injury, and it ranges in age currently from 11 to 18. So this just gives you some idea about impact, which was developed out of the University of Pittsburgh, and basically it looks at the bottom, sustained attention, impulse control, visual motor processing speed, working memory, visual and verbal memory. But the visual and verbal memory on impact is more of a recognition memory task, which basically, like, you're given a list of 12 words, and then you're shown 24 words. I think it's 24, and basically it then you determine whether you'd seen that word before by answering yes or no. So it's not a free recall memory, and it's more recognition for the words. But then there are other ones that are somewhat free recall, where you have to remember three letters, but it's not pure free recall. It does have those recognition memory. It also has skills for selective attention, reaction time, and response variability. Goals of an effective sports concussion program. Obviously, safeguard their health is number one. Facilitate speedy return to play and life activities. And obviously, for the athletic system, reduce risk and liability for student athlete safety and achieve greater success in managing their concussions. The ongoing supports, establishing effective means of communication between school and home, as well as primary doctor, establishing primary contacts for family, both at the school level and administrative level, developing peer supports for the student, and updating evaluations. For treatment, for the concussed athlete, is what we use is if the person has significant anxiety and stress, which is usually the case, we'll work with the person in teaching them stress management techniques, and one modality we use is biofeedback. Also helping them develop a daily schedule, and monitoring their symptoms throughout the day, so they grow in their awareness. Helping them learn to pace to avoid hitting the glass ceiling. Also in the treatment, a lot of times, students are wondering why them. So you will get into questions about faith and spiritual questions and their thoughts about that, and kind of making sense out of suffering-like questions. A lot of them for the first time are struggling with that, especially when concussion goes on and on. And so being able to work with them or work through those issues with them is important, as well as past issues that emerge with the injury, whether they have a history of anxiety or something of that nature, helping them learn the techniques to not only deal with the injury of concussion but also past issues. And then for some, moving into cognitive rehabilitation, which is kind of a brain gym where you're working those different areas that have been injured and helping them, whether it's sustained attention, doing different tasks with them to improve that area of function. So, but not also keeping in mind not to flare the symptoms so they feel so you don't push them through that glass ceiling. So it's a delicate balance between how hard to push, but also monitoring, helping you monitor the symptoms as well as them become aware of that they feel good doing this, and they can kind of see the progression of their recovery. Also in the office, we often see the parents. So a lot of times I'll see the patient, and then my colleague Dr. Mena will see the parents, because parents often have different questions than the student athlete. So questions are answered, treatment options are discussed, medications discussed, developing a strategy to help manage their own anxiety and frustration, especially as the issues or the difficulties continue, and then helping the parents pace the child and provide information for treatment. So important things to obtain from the parents: past medical documentation of the injury, the site of the injury, duration, if it's a coma, or that's more down the line of traumatic brain injury, but also services received already. A lot of times parents are concerned, and so they go to a lot of different doctors to obtain their expertise. So sometimes I've seen people that have seen professionals, two or three other professionals become before coming to our office, and that's tricky for us as well as the patient who's not really sure what to expect. Also, initial evaluations, discharge summary from all therapies, specific recommendations for adaptations for the school environment that have already been obtained, and then therapy recommendations and past experiences within those therapies. Also, psychosocial history of students pre-injury, relevant information on siblings, including how to address their reactions to the injury, and just education of the support team. Also for the educational contact person for the family, the IEPs that have been set up, attendance records, school records, things like that, all give you an idea of what's been going on for this student prior to the injury and after the injury. Obviously educating, heads-up playing, educating the players in how to play smarter and reduce the risk of concussion. Also, strengthening neck muscles and strengthening the core are important. So just knowing the biomechanics and helping the student athlete really develop and strengthen their body before going out to play will just reduce, if they have a strong neck muscle, sometimes will help reduce the acceleration of the head after impact, and then obviously reduce the risk of sustaining sports-related concussion. Also gives them confidence, obviously the padding and having new equipment, and enforcing the rules of the game and discouraging dangerous play. So that's it. So I just want to run through these last few slides about the Brain Injury Association.
Thanks, Dr. Dunkle. And just a quick side note, for any of you that are interested in obtaining resources that have to do with concussion management, the Brain Injury Association of New York State has worked very hard to create two wonderful resources that have to do with concussion management. They're both available for free on our website, www.bianys.org. The first one is REAP. It's based off the well-regarded Colorado program, the REAP project. It's a concussion management program model. It can be easily implemented and adapted for school districts. Obviously, school districts, we know that you all have different resources and needs, so it's easily adapted. And the second is Concussion in the Classroom, which is a pamphlet that was done with SUNY Upstate. And it's a great pamphlet. It provides guidelines for addressing concussion and managing the symptoms, making accommodations for the student that's dealing with concussion in the classroom environment. Both wonderful resources. We are trying to get them out, so please visit our website. If anyone is interested in obtaining hard copies, by all means contact us. You can contact us at info, I-N-F-O, at bianys.org, or you can shoot me an email. My contact information will be sent to you in a follow-up email after the webinar. We're going to start our question and answer session now. Thank you again so much, Dr. Dunkle. We do have some questions already, so I'll start with the first one. This individual says that you mentioned scans such as MRIs and X-rays will show up as normal, but what about EEGs, especially quantitative EEGs?
From my experience, a lot of individuals don't come in with EEGs. I'm trying to think. I don't know. That's actually a question I would have to get back to that person. I'm not totally sure of the answer to that. I'd have to actually research that. I mean, I know EEGs are gonna demonstrate seizure activity, but that's a good question. I'm not totally sure the answer to that actually. Sorry about that.
That's all right. It's a good question. I've heard it actually come up, and it sounds like there has to be more research done on that topic, not just by you, in general. Another question I have, this individual was discussing how a reduction in workload impacts high-end classes like AP classes and ones that require testing regularly. So the inability to participate in the curriculum at the same rate might impact those students. This individual has had students requesting no testing and less homework, but they want to retain their schedules in the AP classes. So this individual wants to know, is it reasonable to expect students to change the level of classes? Parents and students have expectations that obviously have to be accommodated at the same level that they had before the injury, even though some of the symptoms have continued for extended periods of time. I don't know if you have any feelings on that.
No, that's a good question. Actually, I weren't that perfect. But I was just actually dealing with this issue like a week and a half ago. You know, I think on that question that you have to consider if the individual is in AP classes, there are two things to consider. I think one is their awareness of their difficulty. As I said, some athletes or some concussed individuals aren't particularly aware of how the injuries affect them, especially if it's been going on for a long time. And sometimes you have to allow them to go through their own process, because if you say to that person at 16 or 17 or high school student, you know, you're no longer taking AP classes, without them being a part of that decision, and that's kind of their network of friends, that can be a really, really hard thing to, first off, to convince them of, and then to have them deal with on top of the concussion. Now they're dealing with a loss of their social life and their classes. I'd rather see somebody either come to that realization themselves and facilitate in that decision, whether it's decreasing one AP class, if they're taking 3, 4, or 5, and going down to a regular class on their own, versus saying you have to be, now you're in all these classes. And I think it creates a lot of anxiety and a lot of kickback by them saying, I mean, I've had a person say right to my face, no, I'm not doing that. And I think hopefully over the course of time, if you can manage the symptoms, they will regain their cognitive skill set and be able to maintain that level of class. But it's hard to go from a regular class up to an AP. Most schools are AP, and if you go down, that's an easier shift than going up. Typically, I don't see school districts being able to move you up from a regular class. So once they're down, it's hard to get back.
Thank you. I also have another question here. I have a few, actually. You mentioned that the location of the injury might be a risk factor. Do you mean occipital injuries? This person would like to know if you could elaborate.
Well, the site of the injury, we know that frontal lobe function could affect skills such as planning, organization, obviously attention, mental flexibility and problem solving, working memory. So you're going to see if the site of injury is there, you may see decreases in one or all of those skills. So that's what I mean by severity of the injury and the location of the injury. Were they talking specifically occipital, or? It
sounds to me as though they're wondering if being hit in a certain area of the head might affect you differently, or if there's a certain area of the head being hit there that it might be more severe.
No, no, I don't think there's an area of the head that's more severe. I mean, all no, I mean, I think you're going to have different skills decreased by wherever the site is. But if as most of you know, if you get hit in the forehead, you can also have damage to the occipital just because of the contracture indicators from the head hitting the back of the skull and then bouncing forward into the front of the skull, and both areas getting injured.
I have another question here. What is the name of the PRESEASON baseline test, the 25-minute computer-based test? I think this is when you were talking about the impact.
Oh, the impact test, yes. There's impact. Well, that's the one that I'm most familiar with. So that's the name of it, impact.
Someone else said they see that you suggest post-injury evaluation to consist of both cognitive function, they listed impact, and 30-point balance testing. Is there ever a situation where only the 30-point test may stand alone?
Not that I've seen, because you want to measure cognition as well as balance, as well as physical exertion, because first you want to start off with, or you want to do all three simultaneously. And the one thing that the schools use that I work with is they'll when the person is asymptomatic, then what they'll do is they will put the individual through exertion, physical exertion. So for about 20 to 30 minutes on a bike or elliptical to really get their heart rate up, and then check to see if there's any return of symptoms. And then once they do that, they'll move them right into taking impact. So they're doing which is a mental or a cognitive exertion task, and then you're monitoring for symptoms after that. So you're monitoring for symptoms at each stage, and then you make the determination to return to play based on their baseline. But you're monitoring for symptoms throughout that return to play, the first step of that return to play protocol, which is exertion, whether physical or physical, or mental or physical.
Thank you. Someone else mentioned or wanted to know, on computer baseline assessment tasks, is there a safeguard, and I've heard this come up before, against athletes scoring deliberately below par, faking the test results to reach a baseline more easily achieved after getting a concussion? I've heard about this with, star athletes personally, and this individual says they've heard of military personnel gaming the system as well with that strategy.
So kind of sandbagging, they call it?
Yeah, the sandbagging. What are your thoughts on that? Is there a safeguard that you know of?
Well, I think through the, Impact does have some built-in safeguards as far as like various scores on there that can be looked at to see if there is some sandbagging going on. Those are the only ones I know from Impact, but from what I understand from Impact, they're continually trying to develop that aspect of the reliability and validity issues of the test to hopefully guard against that. When individuals take that test, there's like at the school districts, I'm not sure what the program you can run through or have the program run through to pull out all of the bogus tests that any of the students have taken, and kind of selects those, and then the individual has to eventually take the test again. But I know Impact is continuing to work on that issue.
I had another individual point out, talk a little bit about biofeedback and how it can be more than just stress management. Brainwave biofeedback can help re-regulate the compromised brain, retraining it towards more normal functioning.
Yeah, what that person's talking about is neurofeedback. So there's a difference between biofeedback and neurofeedback. I'm not trained in neurofeedback, and I don't use neurofeedback. You know, the research on that, you know, is you know, there's some strong research on that, but I don't use neurofeedback, so I can't really speak to that. I know the biofeedback, just if you're able to help somebody manage their stress after an injury, that will decrease. Well, it'll increase brain function and help them become more aware of what's going on physically for them or physiologically. That oftentimes helps throughout the recovery.
I have one
so
more.
I can't really speak to neurofeedback. No?
Okay, thank you. That's interesting. I have one more question. You may have mentioned this, but is there a difference between a helmeted injury versus a non-helmeted injury?
Helmeted injury and a non-helmeted injury? I don't, you know, I've never heard that question before. I don't think so because I don't think so because the brain, I mean, obviously a helmeted injury, you know, the helmets were developed to obviously decrease, you know, skull fractures and you know, injury to the face. Problem is the brain is floating inside the skull, so it's a matter of physics and G-force that contribute to the injury, which caused the sharing and tearing of the brain tissue. So
this person did add some clarification. The individual said the physician specifically said that due to the helmet, I guess the person whoever was sought for advice here, the physician specifically said that due to the helmet, he was less worried about the concussion versus if it was a non-helmeted injury. I think it goes along with what you're saying, that the helmet can provide some protection, obviously, against fractures, and but you know, if a student is hit, the brain is going to move around, it's going to bounce around.
Right. Right. So I'm not. Yeah, I'm not aware of that. Yeah.
Obviously, I would encourage helmet use. I think equipment that's used is made to help safeguard the athletes. Nothing obviously will protect them fully, but obviously the helmets help. Okay, well, that was the last question that I have. So thank you so much, Dr. Dunkle, for being here.
You're very welcome.
And for presenting. Thank you, everybody, for attending. Again, please check out our website and use our resources, REAP and Concussion in the Classroom. They're great resources, and they're free, so please use them. Please check them out. We do have a webinar coming up at the end of October. You can find out more about that on our webpage as well. If you have any questions that weren't addressed, feel free to send them in an email. Again, you will get my contact information in a follow-up email. Thank you so much, Dr. Dunkle. Thank you, everyone, for attending. Have a wonderful weekend.